So there have been a lot of changes over the past few years. One of the ones that is the most obvious is that patients' out-of-pocket expenses have clearly gone up as we've switched many products, including the hemophilia clotting factor products, to the pharmacy benefit. But at the same time, we've also seen over the past couple of years changes because of the Affordable Care Act, including the removal of annual and lifetime caps. So these benefit changes have made a difference for patients, but also we have new products, and that's made a difference as well. Well, we've learned a lot from new processes of care. The oncology ones are very important, but also we have accountable care organizations, and we have patient-centered medical homes. So one of the things we have learned is that bundles work best for episodic care, not quite so well for chronic care. But in spite of that, we have had a lot of benefit from the oncology care model, which shows that we can get really great improvements in patient outcomes, quality of life, and even reduction in cost. And these come principally from better coordination of care, from organizing care, and providing more supportive care. And they come less from the management of the high-priced pharmaceuticals. So that's something to keep in mind when we set up a delivery system for patients with hemophilia. And of course, we already have Hemophilia Treatment Centers and others who are organized around coordinated care and comprehensive care. So they're already ahead of the game. The barriers here are very similar to those in other places, which is that patients' needs vary considerably. And those needs might vary by patient because one patient has inhibitors, another patient does not. But also patients can have needs that change just because they may be having a bad episode, they've developed a target joint or some other problem, and then maybe that resolves or improves with treatment over time. So being flexible and being able to know when patients are having differences like this, either within a particular patient or without a particular patient. We can only standardize care so much, but we can standardize our approach to patients and making sure that we're asking the right questions and transmitting the right information about each patient. One of the things that we can start with is making sure that everyone knows what an HTC is and what they do and why. Because some recent information has come to light that there are a lot of large self-insured plans that really are unfamiliar with HTCs. Now, most health plans know about HTCs, but they may not know very much, and they may not understand what it is exactly that HTC is doing. So a basic understanding of HTCs is really important. Having direct talks between HTC management and payers, and in particular, making sure that there's an opportunity to speak with the regional medical director or another medical director at the health plan can be extremely important in making sure that they transmit the right information about patient care. And then establishing communications between the HTC staff, the social worker, nurse, and others, and the payer and nurse care managers to discuss individual patients. That is, having someone at the plan you can call when a particular issue has come up or when there's been a change in the status of a patient. This is an issue usually of quantity limits or policy, something that's already published. So in that case, really need to go back to the plan and say, this really doesn't cover things in case the patient needs extra dosing, and especially if that extra dose is an emergency, because we really don't want them to have to go to an emergency department. And indeed, it should be pointed out that many emergency departments may not have all the factors available. So this is something that needs to be brought up to the plan, but it may also need to be brought up to especially pharmacy to have the pharmacy alert the plan, because a lot of times the pharmacy, especially pharmacy, is just going to submit what they know the plan will approve, and they need to ask for that. Plans may push back on this and say, well, our concern is that patients will get extra doses for emergencies, but they might not need them, and now they're storing factor at home, and that can be pretty expensive. And the answer is yes, it can be. Point out that patients have pretty good-sized copays until they hit their maxes, but also the specialty pharmacy could do something here to help monitor how many doses the patient really has at home, and ask the patient when they're going to ship things, did you use up all of your doses, including your extra emergency dose, or can we just send the basics this month or this week? And so I think that there's some need for communication, and certainly there's a role here for the pharmacy. It's rare for a payer to have just one preferred product in this particular category. If they have preferred products, it's likely that they'll have a couple. Now, it may be that these preferred products are in different groups, categories, so there might be one longer acting, one shorter acting, but it really depends very much on the payer. And the impact here varies somewhat depending on the plan and the benefit design. If there's more than one specialty drug tier, so that is if the coinsurance is, say, 25% on one tier, 20% or 15% on another tier, then the big difference between the preferred product and non-preferred product is the impact on the patient's out-of-pocket expense. However, other plans really manage things using prior authorization, and so they may have a policy that says that new starts, so patients newly diagnosed and not being treated on another product, may have to start on a particular agent, but other patients who are already on a particular clotting factor may be grandfathered in. Less commonly, we see requests for people to switch because the plan is only going to pay for a preferred product. And although this does happen, it's rather unusual. Oftentimes, prior authorization forms and their format and even the criteria may differ across payers. But there are some common data elements or some data elements that commonly appear on prior authorization forms. And so what you can do is you can make a list of these and make sure that that information can be obtained from the chart. The biggest reason for denial of a prior authorization and then a subsequent overturn is that all of the information was not provided in the first prior authorization request. So preparing in advance is really critical, and making sure that you can find all of that data in the chart. It might even make sense to have a form in the chart that's sort of a common prior authorization form that you can fill out, and then a lot of that data will be just in one place. Well, there may be idiosyncrasies between plans, but there are some data elements that are really common. And of course, if you deal with a particular payer on a regular basis, you'll learn what idiosyncrasies they may have. But the basics are the diagnosis, including severity. So severe hemophilia A, for example. Some characteristics of the patient, such as age, weight, and if they've had a recent weight change, because a lot of the patients being seen are children and they grow, so that may make a difference. Then if there are particular clinical issues, so again, making sure severity is listed. Is the patient being treated for inhibitors, either treatment to go around the inhibitors or they're on immune treatment for inhibitors? Have they had a recent bleed? Does this patient need an increase in treatment because they're bleeding more? And if testing shows that the patient has a shorter half-life for products, so that they require a different dosing regimen, then that needs to be documented, and there needs to be some information about why the provider believes that to be so. So if you're talking to a plan either about an individual patient or about the participation of the HTC with the plan, have your written materials ready. Understand what it is that you're asking for and what the basis of that request is. A lot of times, plans just want to know, why are you changing a dose? Or, why do you think that patients over the age of 18 should still come to your center? Review the current policy and prior authorization criteria for that plan so that going in, you know if they are in agreement with the way you normally practice, or if there's going to need to be some discussion, and then you can refer to the appropriate places in the MASAC or other guidelines. So having regular meetings with the regional payer medical director, providing feedback on specific patients as well as overall on how things are going and giving updates. Be specific and show results. So what we can do here and what the Hemophilia Foundation can do is to continue efforts to educate the HTCs about how payers work and payers about how HTC work and the benefits of using those HTCs. And I can refer here to the CCSC, the Comprehensive Care Sustainability Collaborative, which is a program with the NHF, Hemophilia Treatment Centers, and payers to share data to improve care and improve costs? Well, they can help us continue the dialogue. They can do this through continuing education programs, both for providers as well as for payers. They can respond to published policies to stimulate discussions with particular payers and create publications and disseminations based on the guideline for hemophilia care, as well as data that can be derived from care at HTCs and other sources showing the outcomes for good patient care, both quality of life, but also comprehensive outcomes such as reduction in bleeds and management of costs.